Welcome everyone. Thank you for joining in this webcast where I was asked to give some sort of updates about what are the things that are happening in our Cath Lab these days. First of all, I want to wish all our Hindu colleagues happy Deepavali. I want to wish everybody good health and safety in this difficult COVID period. Without delaying, we were going to talk about the recent developments in the Cardiac Cath Lab. So Martin Leon, who's a very important cardiologist, said that innovation in medical technology has been key to advancement in medicine. I think that's a given. For example, mortality in acute myocardial infarction has dropped dramatically by 80% since the 50s. And this is largely due to technological advancements, whether it be in the Cath Lab and also when it comes to pharmacology. So today's talk is about recent developments in the Cardiac Cath Lab. First, what are the things that are happening? Of course, the process of doing an angiogram where we put a catheter into, which is now mainly in the radial artery in the wrist. The catheters are getting better. They are smoother. They are less cause less trauma. But the very important thing is our in doing an angiogram, our imaging methods are improving and improving. Now, I'll give you an example. This is a standard angiogram. My pointer is showing the right coronary artery. This is the catheter where we inject contrast, and the contrast material goes into the right coronary, and here's in the left coronary artery. How we assess the severity is we eyeball in different angles. We change the angle of the camera, and here we see what we would estimate to be 20 to 40% degree of stenosis, which is mild moderate, and then more moderate here we'll see 50%, but as you can tell already, these are two-dimensional images. This is the image of a most severe blockage here at 80% blockage. This is in a right coronary artery graft, right? So this is before on the left, and on the right here is after it's been stented. So this has been our standard way of looking, and this is another view where a patient in the right coronary artery, the contrast goes up about 3 centimeters, after which there's no contrast flow, so it's 100% occlusion, and this is after stenting. There's flow down to the mid and distal right coronary artery. So this has been our standard approach. Now, you yourself would have often heard that, sometimes there's a difference in opinion. Somebody said this should have been done, stenting should have been done, and then the next doctor will say, stenting did not need to be done. And so why has there been this kind of discrepancy in opinion? Well, up to now, up to the last few years, our standard way of assessing the degree of stenosis is by quantitative coronary angiography. This is where we will look at a two-dimensional image of a three-dimensional pipe, the coronary vessel, a two-dimensional image here, and then the computer will track the edges, and in here it will give you a reading like it is 80% narrowed. But this is two-dimensional. So here also it shows a two-dimensional view of a left anterior descending artery stenosis here, and the computer will then calculate the degree of stenosis. But as I show in this slide here, 50% stenosis can be a 75% cross-sectional area stenosis, right? And so we are trying to assess three-dimensional stenosis in a two-dimensional way. This is an enlargement of the previous slide. But if you look in this way, in this view, you could have a very severe stenosis, but if the angle of the camera is this way, is 90 degrees, it could look like there's not much stenosis. So this has always been the problem with the QCA. It is not entirely accurate, and not infrequently it overestimates the level of stenosis, resulting in unnecessary stenting. So one of the recent developments for us to assess the degree of stenosis is by measuring the flow across a stenosis, right? This method is called the fractional flow reserve, FFR. So, as I mentioned earlier, angiography has been frequently inaccurate when you measure the hemodynamic significance of a 2D stenosis, right? And it can be even up to 90%. You can get a QCA of a 90% diameter, which is 2D stenosis, and yet the flow is good enough that the person does not need stenting. So now we have this method of FFR, which is considered a gold standard now. So what is FFR? FFR is a ratio. It's the ratio of the blood flow in the presence of this stenosis, say this 50% stenosis, compared to the theoretical normal flow, right? Now, because we don't measure flow, but we measure pressure, but pressure is proportional to flow. So we use a wire that can measure the pressure before and after a stenosis, and then correlate that to flow. So I show you in a diagrammatic way. So when we see a stenosis, what we do is we measure the pressure proximal to the stenosis, cross the stenosis with this what we call a pressure wire. It has a tiny microchip that can measure the pressure here. So when we see that there is a pressure drop of more than 20%, then we know the stenosis is affecting the pressure, and because it affects the pressure, it affects the flow. So if we find that the flow is compromised, the pressure is compromised by more than 20%, then the FFR drops by more than 20%, that stenosis needs to be fixed up. Right? So that has been a fantastic improvement. And when cardiologists do FFR, very often we find that the stenosis that we thought when we eyeball it that it's a severe stenosis, but when we do an FFR, it's not that bad. Then we know that we can treat the patient medically. That patient should not have angina because the flow across that stenosis is not that bad, right? So FFR has, when we do FFR, we will give the patient adenosine during the procedure to maximize blood flow in the heart. So that has been a bit of discomfort for patients. So now FFR has gone a bit further by using certain computer models. They can do the FFR without adenosine, and that's called IFR. And now even a further iteration of this. We don't use wires anymore a lot of the time because we can do something called QFR, which is quantitative fractional flow reserve. And this is by using the angiogram pictures that we have done, and by using computer models, it can give us an assessment of the flow across the stenosis without medicine and without wire. So increasingly, we are moving towards QFR, which is to measure the flow across the stenosis. So by measuring flow, we can see whether the flow drops just by using computer calculations when we do an angiogram. So things are improving more and more. But so with the FFR, decision making with respect to guiding angioplasty has improved a lot. It increases the catheterization time by an average of only 7 minutes at a cost of 22.8 millisieverts and a bit more contrast, about 35 ml contrast. So, but it seems to improve our decision making as far as angioplasty is concerned. So that takes away a lot of the disputes between, disagreements between practitioners as to whether stenting needed to be done or not. So that's FFR. Another improvement in terms of imaging with coronary angiography is IVUS. IVUS is where you use just a catheter which is just about the size, a bit bigger than a wire, which has ultrasound at the tip. This allows us to take an image of the artery from inside outwards and get a 360-degree view of the vessel. So it overcomes the problem of standard angiography, which uses X-ray to produce two-dimensional images of a three-dimensional pipe, which is a coronary artery. So, and it assesses from within the vessel outwards. So IVUS gives us a detailed picture of plaques. It can measure the plaque load. It helps a lot with guiding stent sizing. It improves because a lot of the problems in the past where there is stent failure is because of the wrong stent sizing. And it also helps to identify complications during stenting, especially such things as dissections and thrombosis. So I'll show you a quick video. So, can you hear me? Okay. So you put in a transducer which is like the size of a big wire, and it screens, and then you will get pictures such as this. And for example here, we are coming up to a narrowing. And this is on my cursor now is showing the angiogram. Now here it is white, the contrast is white, and the plaque here is black. And on the IVUS, you can see the plaque here. This is the whole thing is plaque. The whole thing is plaque. And the artery size is actually here to here, which is very hard to assess on an angiogram. So this helps the practitioner, the interventional cardiologist, assess things like the degree of plaque burden, the amount of cholesterol. It also can show you things like side branches, like here. This is the side branch that you see on angiogram, so we can see it clearly. So it gives us a very clear picture of the vessel and a clear picture of the plaque. It very, very importantly helps us assess the size of the vessel. In this case, it is 1, 2, 3, 4 millimeters across. And often, if we just did by angiography, we would tend to underestimate the size of the vessel. So here you can see this is a cholesterol plaque, and here is a spontaneous dissection already within the plaque. And if you did an angiogram and your angle of your camera was 90 degrees to this line, the vessel could look very much normal, because from here to here is contrast. So this is the advantage of a 3D imaging method. So if you look at my cursor from here to here, if the camera was 90 degrees to this line, you would say, oh, the vessel is not occluded at all. Whereas if you come across from here to here and your camera was 90 degrees, you will just see a tiny amount of contrast here. Then you say it is 80% stenosis. All right. So this is the advantage of IVUS, showing us 3D images. 3D images. Yeah. So okay. So these are the kind of pictures one gets. It's quite incredible that we can also see the before the area of stenosis, the relatively normal area, and the distal area. It also helps the doctor, because when you put a stent, you must go from normal, not as much as possible, no plaque to no plaque. Because if you land your stent halfway through a plaque, the recurrence rate of restenosis is very, very high. The other thing that's very useful is after a stent, you do an IVUS. You can see, like for example here, these white bits are stent struts, and we can find in this show what it implies here is your stent is here, but your vessel wall is actually here. So there's a gap between the stent and the vessel wall, whereas you push it right against it, because if there's a gap, there's a high risk of stent thrombosis. So PCI, that means percutaneous coronary intervention with IVUS imaging guidance, has improved clinical outcomes by firstly helping us decide the necessity for the stenting, how to prepare the stent, to prepare the lesion. That means we want to make the vessel as well prepared before we put the stent as before we deploy the stent. It's very important to help us improve stent sizing, to get the stent to go from intima to intima, all right, or media to media, I should say. And then the optimal stent length is also very important, because you want to cover from normal to normal areas, so to avoid what we call geographic miss. And we also, number 4, we want to make sure that the stent is optimally expanded after we do the deployment, and also to identify acute complications, especially things such as dissection, thrombosis, and stent malapposition, right? And then also sometimes when patients come back, that means they have a stent failure. This IVUS helps a lot in helping us decide whether the cause of stent failure was malapposition in terms of stent under expansion. Sometimes things happen like stent fracture, and it helps us, it informs our next form of treatment beyond. The third kind of imaging improvement that we have now is called optical coherence tomography, OCT. Instead of using ultrasound, it uses infrared light, and it gives a detailed picture also like IVUS. The difference is you get pictures such as this, it is particularly useful when we are looking at stent deployment, because we can see, like here, stent struts against the vessel wall. So what is the difference between IVUS and OCT? They are different technologies. The advantage of OCT is it gives very clear pictures such as this, but it doesn't give much tissue penetration, whereas IVUS gives better tissue penetration. So it can see beyond the intima of the artery. So given their different strengths, the OCT gives very clear pictures at the surface, and the IVUS gives pictures beyond. They are starting to look at combined imaging of IVUS and OCT, and that will help improve the accuracy of angioplasty even further. All right. So number 1, this is just at the level, the development at the level of coronary angiography before you do angioplasty. What are the improvements in the lab with respect to angioplasty? A lot of the problems that we have had with angioplasty relate to just give you an example, what we call chronic total occlusions, because very often you find that the occlusion has been there for some time, and they form it start to harden, and it forms what we call a fibrous cap at the beginning of the plaque. So this has been very challenging over the past, over the many years, and the problem is trying to get wires through this fibrous plaque, and very often when you need to try to stay in the middle of the lumen, because if you go to the side and you blow up a balloon here, you could tear this vessel. So there have been many developments in terms of wires that will go through the middle that can penetrate fibrous plaques, tubes, and once you penetrate, you may not even get a tube through it because it's the tube is too coarse to go through it. So you need to have tubes that are very slippery, we call it. But a lot of it has been in terms of techniques. For example, when we if we cannot go through in an antegrade manner, there are some of us, and I don't count myself among them, but there are some of our CTO specialists that will go through. Let's say you have in this case, a right coronary CTO. They will go through the left artery, find the branches that collateralize from the left anterior descending into the right coronary artery, go through the collateral and go through backwards, retrograde puncture, because very often the other end of the distal end of the plaque of a CTO is not as hard as the proximal end of the CTO. So there have been improvement not only in terms of instruments that we can use, but also in terms of the technique. So like in this case, where you can see there's a complete block of the RCA in A. So what they have done here, they've come through the left anterior descending, cross into the LAD, and go backwards and back into the tube on the right side, which is really quite a feat. And then they are able to stent the whole vessel here. So that is called retrograde angioplasty. So techniques have improved alongside with the technology. And also, sometimes when you have very, very tight narrowings or very narrow, where the narrowing is too hard, sometimes balloon just cannot open because there's a lot of calcification. You can use things like a rotablator, which is not new technology, but I'll show you something else. This is a diamond drill. I don't think I'll show you the video on this. It's just a drill that goes back and forth, because if I go into the video, it will stuff up everything again. So the drill will just go back and forth through a plaque, and then create a narrowing big enough for balloons to go through. So then, but now we have now a further development, because those drills can only create a little hole in the middle, whereas this is a new kind of drill. It's called rotational atherectomy. And because you see it's not a central drill, but there's a drill with a bias. So it drills along the side, so it creates a bigger lumen. So for patients who have a big vessel, but the whole vessel is calcified, you have this kind of drill that goes in a rotational way that create a much bigger lumen. So these are all the advances. At first, I want to tell you about the advances we have in imaging to help us improve picture taking and improve decision making when we come to ballooning. Then we have improvements in, of course, I didn't even mention there's a lot of improvements in wires and balloons to help us put the stents where we want them to, because very often the stents cannot get to where the blockages are. So then we have improvements further with things like drills as well. So there's a lot of improvements. Then finally, I just want to come to further improvements now in terms of structural heart disease, right? There are two in particular I'll talk about. One is transcutaneous aortic valve replacement, replacing the aortic valve through a puncture in the femoral artery. So here we will put aortic valve which is on a balloon, and puncture the femoral artery and put it all the way up through the aorta until it reaches the aortic valve, and then deploy it there. So it will then sit over the patient's own aortic valve and allow function. This is useful for patients with severe or moderately severe aortic stenosis, where we feel that they are not really a candidate for surgical replacement. So transcatheter aortic valve replacement is minimally invasive, the minimally invasive procedure to replace a severe aortic valve stenosis, right? And it's at the moment an option for those who are of intermediate to high risk of complications from open heart surgery, surgical aortic valve replacement. Just a quick mention of one trial which was published this year, the Partner 3 trial, which looked at severe aortic stenosis in patients who were not such a high risk, in fact, low surgical risk candidates. So those who were thought to have a peri-procedural mortality if they did open heart surgery of less than 4%, to see whether TAVR, we often call it TAVI, transcutaneous aortic valve implantation, to see whether TAVI is non-inferior to surgery, right? So what they found was that TAVI was associated with a 6.6% risk reduction in death, stroke, or rehospitalization at 1 year when compared to surgery. So the primary outcome was that there was less death. It was a significant finding of less death in TAVI compared to surgery, which is the main thing. So at the moment, TAVI is still relatively new, especially here in Malaysia, and it is often reserved for patients who have severe aortic stenosis, who for various reasons, usually because they're very elderly and frail, who are not candidates for surgery. So, but in the future, as this improves more and more, and it's already starting to show signs that it might even be less, it might even have better outcomes than surgery. It is not an option for aortic valve regurgitation. It's just a treatment for aortic valve stenosis. The other structural heart disease thing that's done in the lab now is transcatheter mitral valve repair. So this is called the Mitra clip. This is where you feed a clip up from the femoral vein, right? Femoral vein, all the way up to the right atrium, cross the intraatrial septum, go into the left atrium, and feed the instrument below into just past the mitral valve to clip a valve that is severely regurgitant. So it looks like such. And there was I want to give you a study called the COAP, the results of the COAP study, which look at patients with moderately severe or severe, in this case, functional mitral regurgitation, not degenerative mitral regurgitation. What does this mean? It means that in some patients with severe cardiomyopathy, where the heart is very enlarged and the mitral valve hinges are stretched out, the mitral valve just does not meet in the middle. So in this study, they used the clip to see whether it reduces mortality. So they found that in these patients who are with a mean ejection fraction of 31%, left ventricular ejection fraction of 31%, with moderately severe or severe functional mitral regurgitation, using the mitral clip reduce 32% in these patients hospitalizations at 2 years, with a 16% absolute reduction in cause of death. So I wanted to give a very broad overview because patients go in the lab and they come out and we don't usually get to see what happens in the lab. Overview of what are the changes that have happened over the last 10 to 20 years. And just as an operator, I can tell you that even day to day, these advances have improved our own performance, right? The stress level is less nowadays, right? We are doing more complex procedures, things like aortic stenosis is being treated in the cath lab. It has improved safety for the patient most of all, but it's also improved operator safety because in the cath lab now, the radiation is less now. We have more methods of reducing radiation to the interventionalists. And also it's expanded the kind of procedures we can do now, such as we are doing much more difficult types of angioplasties. They are doing left main angioplasties maybe about 10 years ago, you wouldn't do a left main angioplasty. It always had to be bypass surgery. You're doing left main surgery, you're doing left main angioplasty, you're doing bifurcation angioplasty, and now we're starting to do structural things such as severe aortic stenosis and severe mitral regurgitation. Of course, the last two at the moment is largely reserved to those patients that are too high risk of if they undergo open heart surgery. So, begging your pardon for all my technological problem with regard to Zoom, but I hope this gives you a broad overview of what happens to patients when they go into the cath lab, and if there are any questions about what we have discussed so far, please message us. I'll try to go to the message screen now. And again, I want to wish all of you good health and safety, especially during this COVID period. I understand from our organizers that this meeting gives each one 1 point with the MMA. I think we might have to start collecting points soon. I think maybe my guess is that points may not be relevant for June next year yet, but I think just in case, we better start collecting our points too. Time to maybe get back to normal. So with that, I will try to get to the message screen. Coronary angiography is still our standard. It's still like a stress test. Are we still needing stress tests? We still do stress tests, but we are kind of moving a bit beyond stress testing. It is still the first port of call. Day-to-day practice is like this. I find I'm doing much less angiography, number one, because I'm doing CT angiography, which often gives me so much of information. Very often now, and almost all the angiography now is done in people who look like they're going to need angioplasty. So almost all the patients would be already, we would be kind of in our minds, we are prepared that they need angioplasty, therefore they will be going for angiography. During angiography, we will do things such as FFR and QFR to measure the degree of flow across a stenosis, to make sure that it's not just a 2D diagnosis that, it is 70% stenosis, or very often in the past, even doctors would just eyeball it and say, oh, you need plasty, so we go ahead and do it. But now it's more scientific inverted commas. Yes, angiography is still needed because we need angiography to do angioplasty. So yes, we still need to do angiography. So what happens in retrograde angioplasty is that we just go through, we have problems going antegrade to push the wire through the fibrous cap. So very often the plaque is softer from the back. So you wire from the back into the main vessel, and then you will start to wire forward again. The wiring is just to give us a guide so that we can get into the lumen, from lumen to lumen. Once you do that, you would enlarge the lumen a little bit, maybe with a small balloon, and then you will start everything antegrade again. You cannot, the balloon does not go retrograde. The balloon can only go antegrade at the moment. There's no retrograde balloon. Only the wire goes retrograde. So what does that mean? So once you get through, you will then go back to standard angioplasty, and the length of the stent will still be based on the standard angiogram. That means you inject antegradely to assess the length of the stent. To be more accurate, sometimes we would end up doing things like IVUS or OCT to assess it better. Yes, that is the next thing that is coming. There's been a lot of studies for CT-FFR. We in our place itself, we are starting to look at that. At some stage, CT-FFR, when that comes, again, that will again lessen the number of people who will need invasive procedures. So suppose you do a CT scan, you see it nowadays. What happens is you do a CT scan, again you will get about 50% lesion, or sometimes you see a 70% lesion, and again it is just a luminogram. So, but the advantage of CT angiogram now is that you can differentiate a lot of people, whether they have minor disease or that whether their symptoms are at all from coronary disease. So the next step beyond that is that the narrowings that we see, we'll be able to assess by CT-FFR. It is not confirmed yet. It's still perhaps in the studying stage, but a lot of places are starting to implement it, and that will help reduce the number of invasive procedures. Yes, CT-FFR is definitely on the cards. Increasingly, yes, but there is a downside of CT angiography is three things. One, there is radiation. Two, you will receive contrast. And three, of course, is the cost, which is about 3,000 ringgit in Kuala Lumpur. Now, will it be a routine test? I think it will be part of our test that we see. So very often First of all, I don't think CT angiography can be a routine yearly check. You are getting too much radiation and too much of contrast. How I use the different modalities is as follows. Number one, where I feel a patient is really of a very low risk, and also where patients do their routine, start with those who are very low risk. I would do a form of stress testing. I nowadays very seldom do stress ECG testing because of the high level of false positives and negatives. So I often will do a stress echo. I don't do plain stress ECG. I avoid stress ECGs a lot nowadays because there's so much of false readings. So where I see a patient whom I think is a very low risk, I will do a stress echo test. Where patients of mine who have gone through angioplasties before, their routine check would be a stress echo, because I will reserve a CT for when I feel they really need it. Where the risk is higher, where patients are, let's say, a male who is 50s, have maybe a smoker, they have some sort of atypical chest pains. Very often I will discuss with the patient, we either do a stress echo or CT scan, CT angiography, with my bias towards a CT angiogram because it gives me so much more margin of accuracy. So a CT scan has been very, very useful. It's much less likely for us nowadays to miss a patient, miss coronary disease, because we can actually see to the inside. And then when we can do CT-FFRs, that will be even more useful. So I don't think we can do CT as a routine test. It's definitely not a routine checkup test because of the radiation and the contrast. So we will still rely on stress testing, especially it's particular stress echoes or stress ECG are particularly useful for those who have known heart disease, who have been treated with an angioplasty, and we need to routinely check them in case we feel that they are not so it's not so reliable to just hang on clinical indicators like chest pain or effort tolerance, because a lot of people have no symptoms, So we'll do routine stress echo testing perhaps every 1 to 2 years, and then perhaps after a long period, when we feel, oh look, it's been 10 years, things are not so optimal, a CT scan would be quite useful. I must say one thing here, that the CT scans have jumped up in the technology, And in the past, where I would not do a CT scan in somebody who has had a stent before, the reason being that the CT scans in the past would have this issue of blooming effect. So if there's a stent, you might find that everything just looks white, and you can't tell the whether there's any stenosis within the stent. But nowadays, with the new technologies and newer CT angiography machines and software, you can actually look quite well through stents. So CTA technology is also improving. It is really quite gratifying to be working in this field, and for doctors to be in the field of medicine over the last 10 years, 20 years, because technology has improved so much already. It helps reduce us relying on gut feeling, and the main downside of these things is that there's a cost to it. Yeah? So we should still try to be as judicious as possible, but it really takes away a lot of the guesswork these days. Yeah. Newer technology like rotational burr, is there a risk of distant thromboembolism? Unfortunately, yes. You are going through a complete blockage. You are drilling. When you drill, there's no suction, to the drill. It's just a drill to yes. So the answer is yes, and we have to sometimes have to retrieve things by doing aspiration, and sometimes just by giving medications. Yes, unfortunately, as we are doing more and more challenging cases that we would have left alone, you do see better outcomes when you look at across the board general. That means when you do these things, you reduce the population risk, but the individual risk going through it sometimes can be significant. Actually, I do. If I'm not wrong, in Canada, I think they have stopped doing stress ECG already. They are just doing stress echo. Stress ECG testing has only an accuracy of about 60 to 70%. The level of inaccuracy is really far too high. So, for example, for myself in my setting now, in CVS, because I can obtain the test. In the past, in other centers, I find that to get a stress echo test, I have to book the patient in, and a lot of patients are unable to find the time to come back a second visit. So I was doing stress ECG as a default. Whereas here in our setting in CVS, we are geared for being just a heart center. We are geared for this, and our technicians are geared to do stress echo on an ad hoc basis without having to book. So I virtually, almost all my stress tests are stress echoes now. The accuracy level is like about 80+%. It is a much higher level than just a plain stress ECG. So I hope I was able to answer all your questions. You can contact us, is it? They can contact us, and if there's some specific questions that we can answer perhaps later on. Thank you all again for tuning in. I hope it gives you a good idea of the broad things that happens in the cath lab, because as I said, you go in, a patient goes in, they come out, nobody can see what happens inside of it, but there's been a lot of new developments, and I wish you all a good weekend. With that, I think our session will be coming to a close. Yeah, thank you.